Hello there, Kim. How are you doing? You've got a sign coming up on mine saying your internet is unstable.
Yeah, mine too. I have a different computer today, so I wonder if that's what's happening here.
Well, it'd be nice if it was yours and not mine.
I'll see if I can switch networks.
Can you see me?
No.
That's interesting because the video is not showing us off. That blue wheel going around. Yeah, that.
Oh, there. Something just came up in the classroom.
I'll just switch.
There you are.
Yes, well worth watching for, isn't it, me? There, we get rid of that. Don't need that. Oh, I'm a bit worried I was going to actually do this on the weekend. I came in on Wednesday. I'm still in quarantine, and
Yeah.
I didn't realise it when I came through immigration and stuff. They were supposed to give me a home test kit, and never did.
Oh, shoot.
So I thought you could just go to a lab, make an appointment, go to a lab, get the test done, and that's it. But no, that doesn't work that way. So trying to find information out about any of this is amazingly difficult. Nobody seems to know anything. You sit on the phone waiting for somebody to answer you for at least half an hour on every bloody call. And finally I got through to somebody and they said, you need a home test kit. So I thought, okay, we'll purulate it to you. So this is yesterday, when I found this out.
Yeah.
So I said, okay, how long is all this going to take? Well, it's 2 to 3 days for the purulate to get you. Then you have to do the test. Then you have to say that's 2 to 3 days again there. So I said, I don't think it's going to work for me. And so eventually, actually, Purulator came this morning.
Oh, good.
But I'm in a condo complex and I'm having trouble with the lobby bell. It goes through my phone. So I answered the thing and the phone hung up on me. All right. I'm not even supposed to leave the condo, but I did. I rushed downstairs. They'd gone. So I phoned up Purulator. Yeah, phoned up Purulator, and he went, "Well, okay, we'll try and see what we can do." He said, "But you might not get it till Tuesday." Oh, well, okay, that's it. Anyway, I was phoning up Switch Health, who does all the testing. They got the new monopoly on testing in this part of Canada.
Okay.
And so they said, book an appointment. So I'm looking through their website. It said home testing. So, okay, home testing, yeah. So I phoned them up. Yeah, we can send a nurse around to it. So I said, okay, listen, I'm in quarantine. My vaccine hasn't been accepted by Canada, which is why I'm in quarantine. Oh, that's all right. We'll send somebody around. So I've got somebody coming around at 11 o'clock tomorrow to do it.
Oh, good.
It's taken me close on 48 hours to get this sorted to that point, and I only just found it by accident.
Oh, wow.
The number of people who could have told me that I went through before. God, I hate governments. They're incompetent dicks, all of them.
It's pretty confusing sometimes here too. Like even in Alberta, you're supposed to call 811 but
oh yeah,
like if you're in close contact, but there's like depending on who you talk to, you'll get 3 different answers.
yeah. I was assuming you can get anybody to talk to.
Yeah,
I've called
exactly.
that now 3 different times, and I've been on there for an hour each time now. Yeah, there's no guarantee anybody's going to talk to you. And any private company will actually say, okay, you're going to record and say, okay, hit 1 if it will call you back when we've got a gap, but not governments.
Yeah. So then when does your quarantine kind of officially end?
If I get the test done and if it comes back negative, I'm out of here on Thursday.
Oh, good.
Yes. Hi, Viv. You're very muffled there. I know, I'm still not convinced though.
Well, I hope for your sake that it comes back and you can get out, because I'm sure you're getting a bit stir crazy.
I'm open for everybody. God. Yeah, I mean, I can't even go downstairs at the parkade. You know, what pisses me off is providing you go back and forward across the border once a week or more, you don't have to be tested. Now, somebody needs to explain to me that outside of the economics of it. So if you're trying to keep Canada safe, how is that an effective idea?
I know, none of it makes sense.
No.
I wish I had better answers for you.
I wish bloody government had better answers for me.
Yeah, you and me both.
Bunch of weeks. Okay, all right, we might as well get going. Do you two have any questions for me? Right.
I don't think I have any questions at the moment. No.
Viv?
Neither do I.
All right. Okay, so what I thought to talk about is a bit about screening tests. One of these is, no, actually, yeah, both of them can be used in the thorax and the lumbar spine. One of them can be used in, no, actually, they can both be used in thorax and lumbar spine. One of them can be used in the cervical spine, but not both of them. And the tests we're looking at are quadrant testing and position testing. So let me see if I can find, I've done some nice drawings if I can find them. Yes, I can. Okay, so I'll put up a slideshow. Okay, so the image on the left there, is, I don't know if you use this, do you? These movement diagrams. This is not normally the way I would draw it, but I'm doing this deliberately. So you've got left rotation, right rotation, flexion, extension, left side flexion, right side flexion. Do you use this?
Not typically.
You've never been taught it? Well, it's really easy. Yeah.
I've been taught it, but I just don't typically use it a whole bunch.
It's a lot quicker than writing, and actually you get a much more direct idea of the ranges. So you'd look, say flexion, let's say they got 50% of the range, you would do, put your line across there, and you would basically do pluses, which would stand for pain. So moderate pain would be a plus, more severe pain, 2 pluses, and so on. And it's the same with all this. And it's actually a good way of doing it. If you've got something that's like a disc herniation where it's limited everything, or a motor vehicle accident, pain, acute MVA, you simply draw a circle right in there. And it's a very quick graphic. It's easy enough to see. Now, what you can see here, this is the quadrants. And so this would be left flexion and left side bending, right flexion and right side bending, left extension, left side bending, right extension, right side bending. So again, it's a very vivid descriptor of it. Sorry, I was on the wrong one. So you've got that going on. Okay. Normally, these things are drawn not so much as a curve, which is the way it originally came in. It's not a bad idea, but with 2 diagonal lines coming fit that way. Okay. So these are the notations for this, and you know, it's an easy and obvious graphic. So if you've lost range in extension and right side flexion, I'll have to come out of that, sorry. If you lost range in extension and right side flexion, you'd simply do that with it. Okay, it'll give you the range loss. You could just draw a line through it if you want to, but that gives you the range loss. And again, plus is for the amount of pain you've got. Now, people will tell you to use this for a disc herniation. So a small disc herniation may limit one quadrant, say flexion quadrant, all right? So you bend forward to the left, it's limited, it's painful, presumably because you're pulling the doer on the disc, the small disc bulge. Coming backwards this way, according to, this is mostly from Mackenzie's ideas, which are entirely wrong for this, but coming backwards into it, you'd reduce the disc herniation, that movement would be free. It's not really the way it works, and you don't need it for a disc herniation. Disc herniations are obvious, you really don't need to do this. So, the argument would be for a bigger one, you'd have flexion and extension painful, for an extrusion, everything would be painful. But that's not the way a disc herniation works. The disc herniation, it screws up everything, everything. So these are old ideas based on Mackenzie and, well, Mackenzie primarily. And it's just not a disc. What he claims is a disc isn't a disc herniation. But where it does work really quite nicely is when you have this situation. They've got full range of motion in the primary ranges, that when you combine them, you find that one of the quadrants is limited. Now, this isn't terribly difficult to understand. Does anybody want to have a crack at interpreting that, how it happens? I've got full ranges normally, but if I go into a combined movement, bang, it's limited and painful. And not terribly much so, but it's there. It's the only movement you find that is positive.
Does it have anything to do with like the coupling of the movements?
Not really, it's to do with the joint. So look, if I do extension, all right, you can see me hands here. So if I do extension, they both slide down. I can do full extension, but it isn't full extension for one of the joints. In fact, it isn't full extension for the joints, because in that full extended position, I can still side bend. So this one comes back more. Similarly with flexion, I can flex both of them, but if I side bend left, I can flex the right one more. Is that okay? Now, it means that you can't simultaneously, bilaterally, fully flex or extend the facets. All right, this has to be a combined movement. Now, it's not got an awful lot to do with coupling, but we'll come back to that in a second. Similarly, if I side bend right, I cannot fully extend the right one, and I cannot fully flex the left one until I do side extension with it. So it's bringing that one down further, so it's able to go more movement. So with a fairly small subluxation, or at least a biomechanical dysfunction, that's what we'll find. We'll find that and not that. Now, that's unusual. Normally, we'll find that extension and left side bending in this case would be restricted on the primary movement as well. But you do get cases, for example, where extension is limited, but the side bendings are not particularly in trouble. And you're going to need a combined movement like a quadrant to fully gauge what side you're in trouble with. So in this case, if that's what's showing up and you've lost extension there, then you'll also find that the left side bending is going to be restricted also. Okay, so the quadrants have uses. They're limited uses, but they do have uses. Are any of you using quadrant testing at all?
No, I don't use it a ton. So Jim, if you put somebody into extension and they had pain, then the next step would be to put them in that. Well,
no, I mean, basically you do what you normally do. If I've
right.
got somebody coming in with what my hypothesis is it's a biomechanical dysfunction.
Right.
The first test I would do would look at range of motion.
Yeah.
So foot flexion, extension, side bending, rotation. Now, if I'm finding I've got an extension loss, I've lost extension, I've lost side bending to the right, I've lost extension, side bending to the right, I know I'm having trouble with the right joint, then I should maybe, although this is variable, one of the rotations will also be positive. Okay. That's not as vital though. The vital information comes from the side flexion and the extension, or the side flexion and the flexion. The rotation is just an added bonus. Okay, so I don't go to quadrants first. I look at the range of motion and then do it. Now, if I find the range of motion is full range pain free, or actually even just full range. Then I'll put them into the quadrants. Or, yeah, or pain free.
Okay.
I'll put them into the quadrants. Or if I've only lost flexion or extension, one of the movements, then I would combine the movement to find out what other movement is affected.
Right. Okay.
Is that all right, Roddy? I might as well talk about coupling now. The coupling that you're told is wrong. I don't care what you've been told, the coupling is wrong. All right. Now, there's been a couple of actual experiments done. Most of this is opinion. And if you look at this opinion, you're going to find Farfan says one thing, Maitland says something else. It's not Syriac, so he didn't get into this. All of these guys who've made an opinion on this, all the major authorities from the 50s, 60s, and 70s, and still have this influence today, they're all different. Every single one of them cannot agree on what the coupling is. You look at the osteopaths, it's in neutral. If I side bend, I rotate contralaterally. If I flex and I side bend to the right, I rotate ipsilaterally. So it's all different. Everything is different regardless of who you bloody read. Now, you can't trust any of them. This is like picking a religion, all right? It's usually the first one you hear is the one you believe. But they're all equally valid, which means they're all equally invalid. We good with that? You've frozen up, Kim. Either that or you're looking very, very sternly when I start to talk about religion. So you can't go on that. Now, there's two studies that have been done that I know of. One is a cadaveric study, and the other one is actually a live subject study using X-rays. And what they did in the live study was they used students, university students, and they put them in a cage, which is about where they belong, and it stopped them from flexing and extending. So what they did then was rotate them, and they imaged them front to back, side to side in the standing position, and then when they rotated them, and they looked at the way the vertebrae were rotating. What I found was interesting. L5S1 rotated ipsilaterally. So if I side bend, if I rotate to the right, it side bend to the right. L45 did the opposite. If I side bend, rotate to the right, side bend to the left. So it wasn't just a matter of the area of the spine you was, it's actually the level that altered this. And L3 was inconsistent, that could go anyway. So this is all about the level that you was talking about. On the cadaveric study, they just did L5S1, and they basically passively moved in these positions. They found that if you rotate to the right, you side bend to the right. If you side bend to the right, you rotate to the left. So now it's not just a matter of which level, it's what initiates the coupling. Now, the problem is, the real big problem here is, even if any of those are true, they're true for a normal spine, and you are not dealing with normal spines. And pathomechanics is not, except by pure accident, the same as biomechanics. So they're almost certainly going to be different from normal mechanics. So we don't care. All I can say to you is that if the right facet can't extend, I will find the extension's missing, right-sided bending is missing, and left or right rotation is missing, depending on which movement requires extension of that right facet. All right, so there's nothing consistent about this coupling, and there's nothing necessary about it. We don't care. All right, because it doesn't make any difference to the diagnosis or the treatment. So who cares? Oh, I was going to go somewhere with that as well. Terrible thing when you get old and stupid. Actually, my brain's rotting in here. I've been in here for a week now, and I know that my IQ is about 50% of what it used to be, which was troubling in the first place. Okay, so you good with that? All right. So that's quadrant testing. It can be useful. It can be overused, and it can be overindulged in, and it's really not necessary most of the time. You use it when the primary movement tests, the individual tests, I'm not giving you as much information as you want. Okay, so the other test that's interesting, and you will be using this a lot with me, and that's position testing. Let me go back to the screen share again. Okay. So if we think about flexion there, okay, so the diagram on the right is flexion. So the vertebra rotates forward. So there's an anterior rotation through the axis of the vertebra, slips forward a bit on the disc. The disc deforms, so it allows it to come forward a bit. And then the facets glide on each other. So the superior facet glides upwards on the inferior facet, and that's bilateral if you're doing flexion. And this one's showing exactly that. So it's gone up, the two facets have gone up with it. If I side flex, this isn't it actually, but if I side flex to the left, the right one goes up and the left one comes down. Is that okay? And so the right one's flexing, the left one's extending. So left side flexion is flexion of the right facet, an extension of the left. Right side flexion is flexion of the left facet and extension of the right. We good with that? Now, let's say, as in this diagram, the lower diagram here, that the left facet joint can't flex. So we try to flex. We're not doing coupling now. We're just flexing the vertebra. And what we find is the right facet glides upwards and the left facet basically stays where it is or is hypomobile. So the upshot of that is this. These are the two facets. So you bend forwards, that should be happening. But in fact, what now happens, because this left one can't flex, that happens. So you end up with the right side of the vertebra coming forward, because it's trying to do that, coming forward, and then it side bends to the left. Is that okay? So it's termed, this is osteopathic terminology, and I'm going to bring it up. It's not really necessary, so don't worry too much about it. It's termed an extended rotated side bent left, because the vertebra has basically done that. Okay, so it's rotated left, side bent left. It's an ERSL. Now, don't worry too much about that. What I can do though is I can go down and I can palpate over the transverse processes. And what I'm feeling for is a transverse process that is firmer to the touch. Now that would suggest that it's rotated around. So basically the vertebra would actually do that. All right, so it rotates that way there. Now, if I find that the left vertebra is back, left transverse process is back in flexion, you've got a number of hypotheses that it could be. One is that I'm hypomobile on the left, because that's basically happened. This one's moved forward, this one stayed back, and you're feeling that firmness of that transverse process. That's one possibility. It's a hypomobility on the left. The other thing is it could be a hypermobility on the right. So they both go forward, but the right one goes further forward. You still end up in the same position. Is that all right? So it's exactly the same terminology. It's extended, rotated, side bend left, but it's not extended, not held in extension, but it's the same position. It could also be that I've actually got a deformed transverse process on that side. So now everything moves okay, and this one stays back because it's back. Same position. So it screens it. So you make a hypothesis that's testable. Now, in this case, my hypothesis would be I'm hypomobile on the left. And you could say it's hypomobile on the right, but the left hypomobility is much easier to test than is the right hyper. So all I do now is do a PA on this left transverse process and see if it does come up. If it comes up, it means that, and you've got a normal infill out of it, then flexion is normal on that side. So it could be a hypermobility on this side, or it could be a deformed transverse process again. Okay, but generally speaking, what you're going to find is it doesn't move up, and you get it's basically hypomobile, and it's normally jammed. So I can now go a step further. I can now say this. Let me write this out. Okay, so I can now say this. We start off with this being a positional statement. Let me glasses on. Okay, so it's a positional statement. Come on. Told you, I'm losing it all. Statement. Left transverse process posterior. All right. Which is, we don't care that much about it, an ERSL. Don't worry too much about it. I then produce a hypothesis that this is hypomobility on the left. I then do a P-pivot. That is, I try and rotate the vertebra with a PA on the left transverse process. Yeah. If it moves, then it's a DX, left hypomobility. Now, I don't know what type of hypo it is, all right? This could be articular, could be extra-articular, and so on. So now I have to assess that end field. Actually, no, I don't. I can assess that end field, but what I'm going to do now is a PAVM, not a P-pivot. So now the PAVM is actually to push the transverse process, not forward to rotate it, but to push upwards to glide the facet. Now, if it moves, I have a left extra articular hypomobility, okay? Because the joint glide is okay. If the PAVM doesn't move, then I have an articular hypomobility. Everything moves. That is a P-pivot and the PAVM, then I have normal flexion. Okay, and what I'm probably dealing with is a compensatory position. Something is making it sit in that position because it can't get into the other. Like it's trying to line the spine up, make things normal. So it could be compensation, or it could be an anomaly. Does that make sense? Time for a bit of discussion now. Are you having any trouble with this? All right, let's start.
I don't think so, but can you just go through that one more time quickly, Jim? Just quickly.
Okay, look, here's your vertebra. All right. I try to flex. That should happen. I should have symmetrical movement, and I won't feel any difference between two sides on the transverse processes. But this comes forward.
Okay.
So this one is posterior. The transverse process on this side is posterior. So having found that inflection, I can generate a hypothesis. Either I've got a left hypomobility, or I've got a right hypermobility, or I've got a compensatory position because something's making it sit in that position. It's mobile, but something's making it sit there. Or I've got a congenital anomaly, which is the rarest one. Okay, so to find out what it is, I can then do a P-pivot. So I do a PA on the transverse process on the left and see if I can rotate it. Now, if I can rotate it, then basically I can flex it. So if it don't move now, I can say it's hypomobile.
Right.
I can't say what sort of hypomobility is. I can say that it is hypomobile. It's either articular or extra-articular. So now I come and do a glide. This is actually absolutely the same as doing a peripheral joint. Absolutely the same. So I now come and do the glide. So now the glide is not forwards, it's upwards. Okay, so I try and glide this cranially. So it's an antro superior glide or supro anterior glide. Now, if that can't glide up, it means the glide is lost. So the joint's the problem. Yeah. If it can glide up, there's a hypomobility still there because the P-PIVM said it's hypomobile. So if the joint can glide, this has to be an extra articular problem. The muscle is holding it, essentially.
Perfect. That makes sense. Yeah.
Okay. If it moves, then there's no joint, there's no movement problem there. And this is about now either a compensatory problem or a congenital anomaly. Anybody else? Viv, Amal, Tulu, Bola, anybody?
It's all good. Thank you.
You good?
Yes, I'm good.
Okay. Extension is more difficult. It's the same principle, it's just the details a little bit. It's a little less intuitive. So look, if I extend, that happens, yeah? The vertebra tips back, the facets slide down. Now, if the right one can't slide down, the right joint is stuck or is hypomobile into extension, then the left one will, and that'll happen. So I'll end up with this left transverse process posterior again, but it's mobile now. So what I need to know is it actually mobile? So what I can do now is I can push on that left transverse process again and see if I can rotate it. So I'll do a P-pivot and try and rotate it. If it can rotate, then this side can extend. So I don't have a hypomobility. The P-pivot is negative. If the P-pivot is positive, though, then I need to check the glide. I need to check the glide on this right side. Now, the easiest way of doing this is to do a glide on the left. So I'm going to try and push this up, but in order for this to go up, this has to come down. Otherwise, this can't go up. So I'm testing the hypomobility on the right by pushing on the left. So I push it up again and see if I can get this one to come down. If it moves down, there's a hypomobility, but it's not in the joint. If it can't go up on this side and this side can't come down, then it's an articular hypomobility. It's okay. It's a little less intuitive, simply because you're doing everything on the other side. But it's not that difficult once you get used to it. But this is a very, very quick way of doing things, very quick. So you move from a screening test, which is your position testing, into a P-PIVM, into a PAVM. So it's a normal, it's just you're putting a screening test in there, that's all it is. You good with that? Now, actually, neither of those two tests work terribly well in the spine, and I wouldn't use them in the cervical spine. The quadrant tests don't take into account the unconvertible joints. So instead of doing quadrant tests, you'll do it's a figure of 8 test. You move the head in the figure of 8, and that takes in the U joints as well as the facet joints. I don't use it very much, to be honest with you, because the other way of testing, the other screening test, is actually more specific to the level, and it's easier to do and control. And that's basically, it might well be what you use, and I don't know, because it's got more popular over the years. But basically, if you want to test extension, you lift that particular one vertebra up into extension, and then you side bend translate that vertebra side to side. So are you using this? Is anybody using this? This is really easy. It's absolutely easy. If they're still teaching you to do flexion, extension, side bend, and rotation, are they doing that in school? Then they should be ashamed of themselves. I'm sorry, but this really sucks. This is what comes of not having clinicians teach this stuff. So you lift the vertebra. Let's say you're testing C2, 3. You lift C2 up so it's extended, and then you simply side bend it a little bit to fix the axis and then translate it. And essentially what's happening is if I've extended it there, and then I side bend it and translate it to the left, so I side bend right, translate left, then I'm extending the facet joint on the right side, and I'm basically bringing the U joint on the right side inferiorly, it's an inferior glide of the right unconvertible joint and a superior glide of the left unconvertible joint. So if I'm getting a positive there, okay, I know it's one of three joints. It's either the right facet, the right unconvertible joint is incapable of extending, is gliding inferiorly, and the left one, or the left one is incapable of gliding superiorly. And then from that, you would glide each joint specifically. So you glide the facet joint on the right, you glide the U joint inferiorly on the left, and you would glide the U joint superiorly on the right, on the left. Okay, so you would follow that up by testing each joint. It is so simple, so quick, and so easy. I think they should be ashamed of themselves if they're not testing that, if they're not teaching that. I think it's really poor. So this isn't difficult, this stuff, and these ways of testing it makes it so much easier. You don't even need that figure of 8 test for this, really. Now, the craniovertebral joints are different, and we'll talk about those later on, but from C2 down, this works really quite well. And then for the thorax, you can do position testing, and then people can pattern that, and same in the lumbar spine. Is that okay?
Yes.
It's a nice, easy way of testing. If you don't get anything else out of this course, if you get that, you'll be miles ahead. But I do hope you get a bit more than that. Do you know Fortin's tests? Everybody?
For the SI joint you're talking about? Yes.
Yeah.
Okay, yes, I do. Yes.
Okay, well, I'm not getting too many replies, so I'm going to review it anyway. Fortin's test, there's actually two types of Fortin's test. There's Fortin's test proper, and there's my test, which I've called modified or objective Fortin's test. So Fortin's test is you say to the patient, I want you to put a fingertip on where this pain is either at its worst or where you believe it's coming from. One fingertip. And then what they should do is put it just medial, slightly inferior to the PSI. It's that specific. Okay. So that's the subjective test. It's part of your questioning, really. It's not a real test. It's part of your history. Objective Fortin's is basically you get into the sacral sulcus and give it a good rub and see if it's tender over Fortin's area. Now, Fortin's test proper, the subjective Fortin test, has been semi-validated. It was done by Fortin and Falco, but they screwed it up. What they did was they took a good number of people where the subjective Fortin's was positive, and then they injected the SI joint with 2 anesthetics. That's standard, short acting and long acting. Then they saw what happened to the pain. And Fortin's test was extremely accurate as far as reacting to the pain. So it means it's very, very sensitive, all right, close to 100% sensitive. What they didn't do, though, was use a control group. So nobody has any idea of how often you have a false positive, false negative, isn't it? Nobody knows, but it's very, very sensitive. So it does have its uses. The big one being that if Fortin's test is negative, you can be pretty sure that it's not the SI joint. All right, it may not be 100%, nobody really knows, but it's very, very high. It has been given a value of 100% by some authors, but I'm not sure that you can actually say that, but it's close to 100%. So it's useful for saying it's not the SI joint. I've only ever seen one SI joint that I've done objective Fortin's test to, where it hasn't been positive when they've had a SI joint manipulation that basically responded to a manipulation. So this doesn't have the same research rigor, obviously, as doing this as a random control trial and everything else. But from my experience, this thing works quite well. Now, the thing with the Fordin's test is, subjective Fordin's test, is that if the patient doesn't have pain in that SI joint, but the SI joint is jammed up but asymptomatic, then Fordin's test is going to be negative. So it only works when Fordin's test is painful, when the SI joint is actually the source of the pain. Objective Fordin's test, though, works when it's not painful, when it is jammed up, in my experience. So, and you may have to rub hard, but you have to rub both sides equally as hard, and one side will be more tender. So this is down, a lot of this is about operator error. But if you can make sure that you're putting the same amount of pressure through on these people, you're going to find asymmetry in the tenderness. Right? That is a test, both tests, I think you want to practice doing on patients. You come alive there, Bo. What do you want?
Did I pop up on the screen?
You ever got a question for me?
Nope.
Okay. All right. And of course, the other screening tests are PAs. Don't forget PAs. So you can use them as a screening test, but they're better off using them as a test to rule out things. So if you're thinking that this may be a visceral pain and not coming from the spine, or it's not coming from the spine at all, then PAs will help you in that, because you'll do PAs and they will not be as positive as they should be, if at all. So these are actually a lot better for confirming that this isn't a spinal problem, because every spinal problem, you're going to have positive PAs. So it's not particularly useful as a diagnostic tool. It will, of course, tell you the likely level as well. Okay, but it's not that great for making a general diagnosis, because every spinal problem is going to have a positive PA. You okay? I'm almost finished on the lumbar spine, I think, as far as this is concerned. Does anybody have anything for me on the lumbar spine you want to talk about? No? Okay. Let's talk a little bit about dizziness. We've got time. I think I've done this with you before, but it won't hurt. We're going to get a lot of this on the course, so it won't hurt to do this again. The best definition of dizziness I've heard is it's a sense of disequilibrium. You feel unbalanced. And your problem is determining what the pathology that's causing the dizziness is. All right. Now, if you look in textbooks, they will talk about it being central or peripheral etiologies, but that don't help you. It really doesn't, because you've got to talk about this in terms of symptoms, not about etiologies. You have no idea what the etiology is until the patient describes their symptoms. So before you get to that etiologically based diagnosis, you need to do a symptom-based diagnosis. And that's the three types of dizziness: type 1, type 2, type 3. So type 1 is an illusion of movement. Either you're moving or the environment's moving. Generally speaking, it's vertigo, a spinning movement. But that's not the only type. There's another one called oscillopsia, which is a swaying movement. It's like it's an oscillating type thing. And it's often this way, but it can be up and down, and it can be side to side, and it can be backwards and forwards. Now, from my understanding from vestibular therapists, oscillopsia tends to be a bilateral problem, whereas vertigo tends to be unilateral. Some of that doesn't make any sense. You get vertigo when you're drunk, but the booze doesn't rush to one side of your head. So I'm not sure how that works. I'm not actually convinced about that statement at all. But it's very rare for us to see oscillopsia. Vertigo, though, is much more common. And I'm sure you've all experienced it, either through drinking too much or as a kid making yourself dizzy when you're spinning around and around. So that vertigo is then accompanied afterwards by nausea and possibly vomiting, lightheadedness, and ataxia. Yeah. So when you make yourself dizzy with vertigo, you go through all three types of dizziness. Type 1 dizziness, the illusion of movement. Type 2 dizziness, which is also called pre-syncope dizziness, which is what you get when you just before you faint: nausea, lightheadedness, wooziness, giddiness, and so on. And then type 3 dizziness, which really isn't dizziness at all, but is actually disequilibrium. So it's not a sense of disequilibrium, it is disequilibrium. It's put on there as a courtesy more than anything else. So you can nitpick this if you want to, but that's what it is. So if we look at type 1, it's usually vertigo, and the normal place for vertigo, the axis is through your head. And if you're laying down, it's through your heart. Yeah. So you're either spinning like that, or the room's spinning in that plane, or if you're laying down, you're spinning horizontally. But you can also have it around a sagittal axis. So you imagine an axis going through that way out there, then you'll somersault forwards or somersault backwards. Now, those last two are rare and they're usually not particularly benign. The one that really isn't benign is when somebody describes herself as backward somersaulting. And that's usually caused by major problems like cerebellopontine tumors, Arnold-Chiari malformations, really nasty stuff. And that's accompanied by true downbeat nystagmus. So as you're going back, your eyes are going down. And that's true downbeat nystagmus. It's not curvilinear, it's not going laterally and down. This is going down. Downbeat nystagmus, again, is always, you always have to suspect this is a serious, serious pathology and it needs investigating. But I wouldn't be happy with either one of these, forwards or backwards. I'd be very unhappy about one going backwards, but going forwards might not be as severe. But neither of them are very common. I wouldn't mess with these. I wouldn't send this to a vestibular therapist. This would go probably to the emergency room rather than the physician. If it did go to a physician, I'd want him to send it to probably an otoneurologist, somebody who knew what they were doing, not an ENT generalist. Is that okay? So type 1. Now, central versus peripheral with type 1. Central vertigo. The vertigo is persistent. It's mild. All right. Yeah, I can feel it spins a bit, but I can live with it. But it does go on. So whatever triggers it off, this can last for varying amounts of time afterwards for a long period. Whereas peripheral vertigo, it's severe. You sit down or you fall down. And also, it's not persistent. It's usually gone within about 30 seconds of the trigger stopping. Central vertigo can change directions, both during the attack and between attacks. So you might start spinning this way, anti-clockwise, and then suddenly it'll start swinging the other way. Or one attack will be clockwise and the other attack will be anti-clockwise. They're both hallmarks of central problems, neurological problems. Whereas peripheral vertigo is consistent within the attack and between attacks. So vertigo is fairly easy to classify. And so is the nystagmus that tends to go with it. As I say, basically the nystagmus is going to go in the opposite direction to the way you're spinning. And that's sort of reasonably normal. And it should only come on when you've got the vertigo and no other times. Now, if you drink more, this is for semi-professionals now, if you drink more, there's a condition called bobinoscillopsia. And it's about the time you figure that you can probably see and walk straighter if you close your eyes. So you close them as tightly as you can and still see where you're going. Then every time your foot hits the ground, the buildings do this, boom, 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 boom. It's like a dampening effect, and it's really weird, entertaining as hell, but it's only for the semi-pros. Yeah. Type 2 dizziness is much more difficult to classify, much more difficult to classify. And it's also, whatever the patient says is dizziness. You haven't really you've got no say in this. If they say it's dizziness, it's dizziness. But that can be anything from vomiting to nausea to lightheadedness, wooziness, giddiness, fainting even, they'll call that giddiness. And you've got to accept that it is dizziness. Now, trying to sort this out as to whether it's central or peripheral is really tough. First off, if they have vertigo with type 2 dizziness, this is not peripheral. You get vertigo with, you get nystagmus with vertigo because this is a screwed up vestibular ocular reflex. This is neurophysiological, but if you get nystagmus with type 2 dizziness, this is neurological. So straight away, as soon as you see any nystagmus for this is more or less an emergency situation. Certainly urgent, if not emergency. All right. Any neurological symptoms, which is rare with VBI, but any neurological symptoms accompanying either vertigo or type 2 is enough for you to get into the emergency room. All right. Otherwise, it's really difficult. I would suggest that anybody who's still got type 2 dizziness 10 or 15 minutes after the trigger stopped should probably go to the emergency room, right? Particularly if it isn't getting better. What you can do with type 2 that you can't do with vertigo, though, is you can do a cranial nerve exam on the patient. So while the symptoms, neurological symptoms, may well be absent, particularly with VBI, the signs are not likely to be, so you can look for positive cranial nerve signs. Is that okay? Type 1, type 2. Type 3, disequilibrium is fine if they've got dizziness, vertigo, or oscillopsia. If they've got type 2 dizziness, it's not fine. All right, that's neurological. If it's appearing without any of the dizzinesses, that's neurological as well. And you see this in older people. It's a sexist term, but it's called old man's disease. Take great exception to that. I'm surprised the feminists don't get involved on this if they want equal opportunities. So they're staggering around, but we know dizziness. This isn't about the dizziness now. This is about ataxia, basically. I remember Bob Sydenham telling me once he had a patient come into his clinic and he was slow and he was leaning on his clinic door and he was chatting to somebody out there, and along the hallway comes this guy and he's leaning against the wall and just walking towards his office, and he stops where Bob is and he went, "You all right?" He went, "Yeah." He said, "Why are you up against the wall?" He said, "I don't know." He had lateral ataxia. So he kept walking laterally until he hit something and walked along that thing. But he was in the middle of a stroke. So you've got to keep your eyes out about this. Dizziness isn't always benign. And what I'm going to tell you on this course is, until you are better and more confident at diagnosing dizziness as a benign condition, you use dizziness as a contraindication to manipulating the neck. All right. Once you're confident with this, once you've done it a few times, you're happy that you can do this, different animal. But until that point, stay away from manipulating. It's just not worth it. Right. If this does happen to VBI, you can do a lot of damage both to the patient and yourself. It's very unlikely, actually, if you cause somebody to stroke or kill them, you're probably not going to want to do this job anymore. You certainly won't want to treat necks. Okay. The closest I came to it, that I know of anyway, is I had a young guy, motor vehicle accident patient, sometime before the car accident was. He was about 29, I think, something like that. And he had neck pain. And he had suboccipital pain on one side, and he had lower cervical pain. And he had some dizziness. And I said, "I have no idea where your dizziness is coming from." I manipulated the lower neck, got rid of that easily. That just a traction neck, got rid of that. So I said, I don't know where your dizziness is coming from. So I said, listen, I want you to go back and see your doctor and have him look at you. So instead of doing that, he went right and went into the chiropractor and manipulated him. And 10 or 11 days after that, I got a phone call from one of the local doctors. At the time, they were all doing stints in the emergency room. All the GPs were doing stints in the emergency. This wasn't a big city, so they were doing stints in the emergency room. He phoned me up and he went, "Got one of your patients in here." So I said, "Oh yeah." So he said, "What did you do? How did you treat him?" So I said, "Yeah, neck problems." I said, "I did tractor manip on the base of his neck, got rid of that." He said, "How was he of it?" I said, "It was fine." I said, "But I sent him back to his doctor because he had some dizziness there, and I wouldn't figure out what." He said, "Yeah, that's what he said as well." He said he went to the chiropractor, he manipulated his neck, and he's now got a central stroke. He had not an infarct, but he had an embolus blocking the. It was a basilar, I think. Anyway, they cleared it off. I spent the next 2 years sweating about a lawsuit, and never came. He sued the chiropractor, never touched me. Which is unusual. They usually will fire off at everybody. Do you know why you don't get sued? PTs, it's very rare to see a PT sued. Any ideas? Doctors get sued all the time, and it's got nothing to do with competence. The numbers are the same. Really good doctors get sued as often as really shit doctors. And the one factor that determines whether you're going to get sued or not for malpractice is whether or not the patient likes you. That's it. You're already in a good position there because you spend time with them. You show an interest in their problem and they're happy with you. And they like you because you're interested. So you tend not to get sued. And I think we was talking about this last time about using pain scales. Was it you lot I was talking to this about? This is one reason not to use pain scales. Get the patient to like you. Even if you think they're a scumbag, get them to like you. All right. Makes all the difference in the world. But that is it. That's the mitigating factor on who gets sued and who doesn't. Okay. Anything else you want to talk about there? So who's on the course this weekend? One of you? Everybody else up in Edmonton?
Yeah.
Well, I know that I'll be there for that one. That scared the crap out of you, hasn't it, Bola?
I didn't get that.
Just as well, really. I'm hoping that I get to the course on the weekend.
Oh, please. Please do.
I'm in quarantine and I couldn't get a test.
Ah,
I couldn't get a test because they didn't give me a bloody home testing kit at the airport hour. So I've got a nurse coming around here tomorrow to give me one.
oh, okay.
So providing I get it and it's negative, I'll see you on the weekend. If every of those things don't happen, if I don't get the test or it's positive, you won't see me. I'm not sure what we'll do.
I thought that should be next weekend, right?
Yeah, we are Calgary team, right?
Oh, yeah, yeah, yeah.
It's the 10th.
Yeah,
Oh,
Calgary.
Yeah,
Okay.
10th. Yeah, that one. That's what I'm talking about.
Oh, yes.
I'm stuck in here for this weekend. I'm only on day 8 of this. And it feels like 2 years. And I do know my IQ's dropped a lot. My social skills, such as they were, pretty much non-existent. I've been fueled by adrenaline for the last 2 days trying to deal with government departments. And the worst of it is I can't get rid of it because I'm stuck in a 900 square foot condo. So I want to kill somebody. Can't exercise, my blood sugar's building up. Lovely. This is really fun, this. And I'm trying to buy a car in Medicine Hat.
Oh, okay.
It's not okay. Doesn't anybody care why I'm trying to buy it in Medicine Hat?
I was wondering why not Calgary?
My son lives in Medicine Hat. His girlfriend is a car salesman for Toyota in Medicine Hat.
Oh.
So I'm trying to give her the money rather than them down here. I'm leasing. If I get too much shit over this leasing stuff, I'm just going to buy one. I think. Trouble is, it's going to sit in the parkade there nearly all year. Gets used about 3 or 4 times a year, if that.
Yeah.
But they wanted $4,800 to rent a car. I've got it booked. $4,800 to rent the car for the next 3 months. It was a full-size SUV, which I don't want. And then, because that was the cheapest one. Yes, the big SUV was cheaper than anything, a lot cheaper than anything else they had. And so then I get a phone call from them saying, "Oh, we've changed your car." So I said, "Oh, good. Something smaller?" He said, "Oh, yeah." So I said, "What?" He said, "A Chevy Spark."
Oh,
I said, "You don't what?" I said, "At least there won't be parking problems. Just put it in my bleeding pocket."
Oh, boy.
I'm looking at a Toyota Corolla.
oh yeah, that's a good one.
Those are
That's a
good
very good
cars.
one. Yeah. That's
It's
a
a
very
little
good one.
speeder. That's what I want, is something that really takes off and kicks off, and it's a dragger, is it?
Yeah, it's a good one. Yeah.
No, it's not. It's not a dragster, is it?
Not quite, but close.
Probably just as well. Probably.
Almost.
I've got used to driving a Nissan. Is it a Nissan Verna? No, Hyundai Verna.
Oh.
God almighty. My wife bought that off of some friends. We had an Explorer. It's in Mexico, and I had friends who were coming back to Canada who were driving this shitty 10-year-old Verna. I mean, you never call a car a Verna. What the hell is wrong with it? And I've got used to that little thing. So it's actually slowed me down because I've really got heavy foot. So it's done me a favour. So the Corolla's probably a good car for me. I'll save me a bundle on tickets. If I get out, ever get out of this condo, I'm going to think I won't. And I've only just mastered online shopping as well.
Oh yeah.
Uh,
Don't get caught in that. They're
I've
gonna
got no
lose all your.
choice. They won't let me go and buy anything.
They're gonna buy too much.
No, I've done this, and I know perfectly well what I'm like when I go in there. I come out with about 3 times as much as I ever need. I've got no control, absolutely no impulse control whatsoever. All right, guys, that was fun.
Yeah.
I'll talk to you on Thursday, I guess.
All right.
Do you want some videos? I've got a bunch of videos that I'm making for the other group. Do you want me to send them to you?
Yes, please. Yes.
All right, I will do that. I've got all the time in the world to put them on YouTube. So,
Okay.
all right, guys.
All right.
care,
Thank
everybody.
you. Have a nice night.